This is Chapter 17, Rehabilitation of Shoulder Injuries. First three slides display the anatomy and some of the biomechanical considerations. This slide shows the bony and what we call the shoulder girdle muscles in the anterior and the posterior. This slide has a little more specific view of the glenohumeral joint and the muscles and structures surrounding it. It does not have ligaments indicated that surround this area, which will be noted soon when we talk about injury to the bony structures. This slide demonstrates the various scapular motions. The nice part of these pictures is that it shows the individual performing the glenohumeral motions that coincide with the scapular motions. These are important to note because dysfunction of these scapular motions can be the root cause when a patient shows up with shoulder pain. This can be especially true in an adolescent or high school patient without a great amount of wear and tear on the rotator cuff musculature. We'll talk about that a little later. To do some of the things noted in this slide, exercises are needed. Pages 452 through 479 in the book have pictures of various range of motion, neuromuscular control, resistance training exercises, and functional strengthening exercises. Between the book and simple set, you should have plenty of things to use for a shoulder rehab. Make sure you look through those pages to get familiar with the various exercises. I'm sure you have seen plenty of them being used in clinical practice. Hopefully, as we go through this lecture and class discussion, you'll understand why they are done. Remember the upper body and chopping, lifting, PNF patterns from Chapter 14? Those are great ways to promote neuromuscular control and strengthening all at once in the shoulder. Just like the other presentations, this slide is the template for what you need to do in a rehab. Never forget this. Now, here comes the meat and potatoes of the lecture. These next slides will discuss some of the injuries you may see and their specific considerations as it pertains to rehab. Hopefully our conversation in class should help to bridge the gap between the considerations discussed and what you will do when faced with these pathologies clinically. Sternoclavicular joint sprain is the first pathology listed. You can see these in rowers, gymnasts, or golfers. This joint is relevant because of the clavicle's articulation with the scapula. Even though this is the proximal end of the clavicle, it can still play a part in shoulder kinematics. Scapular upward rotation, which happens with shoulder abduction, will probably be the most problematic motion on the involved side. Most shoulder motions at the end range will be uncomfortable initially due to the movement that occurs in the clavicle in these arcs. AC joint sprains are next. 6 types of AC sprains are listed on page 482, table 17.1, or you can click on the link for an overview. These injuries are classified with an X-ray. Typically, type 1 through type 3 are treated non-surgically, while type 4 through 6 are treated surgically. Post-surgical recovery involves a longer immobilization to ensure the clavicle and scapula are realigned compared to the non-surgical. After immobilization, progression is similar in both. Deltoid and trapezius muscle strengthening is a large focus, and pectoralis major strengthening is also noted. After that, assess the shoulder complex and make sure to address any other deficiencies that this injury may have created. Clavicle fractures are like any other fracture. They'll take 6 to 8 weeks to heal and should have minimal motion while that callus is forming and solidifying. After that, you will treat it like the AC or SC joint sprains to ensure the clavicle is working appropriately to allow the scapula to do what it needs to do. Glenohumeral instabilities and dislocations are next. When thinking about the glenohumeral joint, there are 3 directions that the humeral head can possibly go due to bony anatomy. The most common direction for a dislocation by far is anteriorly. Posterior and inferior dislocations account for around 5 to 7% of all shoulder dislocations, with inferior being rarer of the two. 2 things you will hear with glenohumeral dislocations are Bankart lesions and Hill-Sachs lesions. Both occur with anterior dislocations. The Bankart lesion is a defect on the anterior labrum. The Hill-Sachs lesion is a defect on the posterior humeral head. This occurs when an anterior dislocation is out for a prolonged time and the glenoid rim puts pressure on the humeral head. We have two acronyms for mechanisms of anterior glenohumeral dislocations. Traumatic, unidirectional, Bankart lesion, surgery required is TUBS. Atraumatic, multidirectional, bilateral involvement, rehabilitation effective, inferior capsule shift recommended is AMBRE. TUBS dislocations have high likelihood of recurrence, but any shoulder dislocation increases the chances of a subsequent dislocation, regardless of mechanism. Multidirectional instabilities are a little trickier than unidirectional instabilities, simply because there is more dysfunction to control. The concept is still the same, though. Stabilize the joint while trying to promote functional mobility and strength. I have a SLAP lesion handout linked in this slide, along with some of the supplemental information within that document. Please look over the information because we will talk about it during class. You can also look at the rehabilitation plan on pages 496 to 499 for an example of how a SLAP lesion post-surgical repair rehab will look. This next slide discusses some exercises and positions that should be avoided or modified when dealing with the various types of dislocations or instabilities. Regardless of the direction of instability or if it was treated surgically or conservatively, the protocol of rehab remains the same. In this condition, creating stability while promoting appropriate mobility and strength is a delicate balance. Performing a thorough evaluation and continual reevaluation of all the structures in and around the shoulder, trusting your evaluation, following standard rehab principles, and strengthening everything around the glenohumeral joint that you can will help create positive outcomes. Shoulder impingement is the next pathology discussed. The book discusses two separate grading systems of impingement. It is not important which one you use or know, but you should know what symptoms are typically present with impingement. That leads to the question on the slide. Which two tests are the go-to special tests for shoulder impingement? They are discussed within the grading systems and they are pictured on page 491 and 492. Answer in your head, then check to see if you are correct. Impingement can stem from anatomical or functional causes. You can see an example of how the anatomy impinges in a space by looking at the acromion shapes. The hooked acromion essentially digs into the tissues within the space. Forward shoulder posture can also compromise the space under the coracoacromial arch. What athletes do we see this commonly? A better question may be, is there anyone that does not present with this due to cell phones? This transitions into the functional use by underlying theme to many of these situations is the rotator cuff does not appropriately compress the humeral head into the glenoid. If the humerus migrates superiorly and or anteriorly, that also compromises that coracoacromial arch space. Another reason for impingement is the force coupled between internal rotators and external rotators could be off. Subscapularis tends to be disproportionately stronger than the external rotators in throwing athletes, leading to the humerus being pulled more anteriorly than it should. There are many other possibilities as to why impingement occurs. This is where the evaluation is of the utmost importance. Page 493 to 495 in the book has the section on injury mechanism that you may want to mark for later reference, especially those of you who wish to be around upper extremity athletes and patients. The next condition noted in the book is rotator cuff pathology. This is like impingement, as many of the same soft tissues are involved. As I have in the slide, there are varying degrees of impingement. Especially in overhead athletes, continued use can make the injury progress through that flow chart. When dealing with adolescent or teenage patients, rotator cuff pathology usually does not happen without some sort of underlying anatomical anomaly. Most rotator cuff tendons stay viable through these years. If we begin to discuss overhead athletes in the college and our professional ranks, we will begin to see the potential for rotator cuff pathology due to overuse. However, you will probably note some of the impingement issues that cause pathology to the rotator cuff. In middle-aged patients, bone spring from years of use can speed up the progression of the rotator cuff pathology. As with impingement, you should try to find the root of the problem, which may not be specifically at the glenohumeral joint. If there is a surgical intervention, there are differing opinions as to how long you should allow for the initial inflammation to settle. If you have a patient with rotator cuff surgery, Be sure to consult the surgeon for their preferred progression. Frozen shoulder is next. In the population we see clinically, this is more likely to occur secondary to another pathology. Table 17.3 on page 504 has some of those differential diagnoses listed. To properly rehabilitate this injury, you need to figure out the reason why the joint had lost motion. After that, the progression follows the same protocol as many other pathologies discussed. Thoracic outlet syndrome is a condition that is not common, but it seems that there is a case or two in the athletic training clinic every year. This pathology comes with neurovascular symptoms. There are various structures that can cause the impingement of the brachial plexus, subclavian artery and vein, and axillary vessels. Clavicle, the first rib, an X-rib known as the cervical rib, scalene muscles, and the coracoid may all contribute to compressing the neurovascular bundle. Finding the reason will point you to the rehab. One thing, though, that can help regardless of reason is maintaining an upright posture. Focusing on the posterior shoulder girdle muscles can help promote the balance between the anterior and posterior muscles that many patients lack. Brachial plexus lesions are next. What sport do we see this injury occur, and what is the mechanism? Stingers or burners tend to be transient in most cases, but continual trauma can lead to decreased strength in the monotone pattern of the involved nerve root. When I think of this injury, the first thing that comes to mind is making sure that appropriate tacking foam is being used. If that is sound, then you can make sure to mobilize and strengthen the neck and shoulder girdle muscles, along with any that may be weakened by the trauma. We have talked about myofascial trigger points in the spine, and in that lecture I said they were everywhere. The shoulder is a common area to find hypothalamic areas of muscle as well. There are many overhead athletes who develop these with repeated flaws in the mechanics. The muscles are not working efficiently, and that can create irritated spots in the muscle or fascia. Treatment usually involves soft tissue immunotherapy or other modalities. This, combined with addressing any biomechanical issues, should make the trigger point subside. We are going to talk about the various exercises and considerations for these injuries in a practical sense during our class time. I do want to say a few things before we dive into this in class. First, the shoulder is almost as complex as the spine, and I said the spine was really tough. We will talk about some of the literature and concepts out there over the next few class sessions. Also, I will try to unify this, but there are many different names for exercises. If you see something with a name like Sharapova's, that does not describe what to do. Be familiar with exercises that you see in the book, in literature, in Simple Set, or elsewhere. That makes things easier when we talk in class. More importantly, it makes things easier for you as a clinician and makes things easier for your patients.